Well, thanks very much for inviting us today. As Jane said, we've got 3 speakers from SHOT, and I'm going to start off by setting the scene and talk about what we've learned from SHOT IT errors. And just to put this in context, the SHOT IT chapter is a composite chapter. It's drawn from the all the other reports that you put in. It actually started in 2006 when Derek Norfolk was responsible for this area, and then I took over in 2011 and then was joined by Jenny Davis and Alistair McGran from about 2018 onwards. It may not always be at the top of your reading list when you read the SHOT report, but I think it is definitely worth reading the SHOT chapter, as it is worth having a look at our SHOT Bite 13, which has been there to guide you and also to share with your IT people to explain some of the challenges, if you like, in IT as it relates to transfusion. Jenny's going to talk about the script initiative later. So for this composite chapter, we take these sort of errors. We look at errors that have been caused or contributed to by IT systems, errors that have been caused by using IT systems incorrectly, to a certain extent where implementation of an IT solution would have or could have prevented the error, and where people mention their corrective and preventative action in response to an error, we include those as well, because I think there's learning in that. It also is a little bit wider than just IT systems. It includes automation, it includes other equipment as well. So if I go back to 1999, 1920, 2000, this was the recommendation that was in the SHOT report that year. So this was before there was a SHOT IT chapter, and actually it really was in capital letters, so it was quite shouty. I would say that it was definitely visionary and set the scene for IT and transfusion. There was a view then that if we had IT across the piece, it would prevent human error. There were increasing availability of the identification systems for transfusion that were available but not fully evaluated. And the recommendation was that the NHS should take a lead in assessing this new area of technology. So where have we gone since then? Well, the UK Transfusion Laboratory Collaborative was set up to consider the increasing number of IT-related, laboratory-related errors in transfusion. And as you know, there are initially recommendations and then standards, and these are the standards that relate to sort of automation and IT. So first of all, we should have walk-away automation, which is bidirectionally interfaced. Have we achieved that? Yes, I would say the majority of people have achieved that within their laboratories. That we should have electronic issue of red cells, and that is probably present now in about 2/3 of laboratories. So it's definitely not universal, and to a certain extent that is because the computer systems are not always compliant with what the guidelines and the MHRA would want us to do. But actually the area which was recommended way back was to consider installing complete blood tracking, particularly when you have other systems in place. And I would say probably less than a quarter of hospitals across the UK are doing this. So in 2015, SHOT took stock a little bit and looked back at what we had reported through our IT chapter, and we came out with these themes that really map to a lot of the errors that we were identifying. Certainly, SHOT continues to promote the benefits of existing IT systems. They make systems safer. They take away a lot of manual steps, and they certainly are forcing functions, if you like. They promote safe practice. But actually, if you don't make sure that they're working correctly or have been set up correctly, that's one of the steps where things go wrong. If you don't assure your data integrity or the security of your data transfer across interfaces, then there will be problems. If you don't put the right data in, and if you don't manage data correctly, then that won't lead to good outcomes. And above all, you absolutely have to train people so that they use these systems correctly and as intended. And just to exemplify that point, you know, IT systems do make transfusions safer. They can control clinical and laboratory tasks, but they absolutely don't replace knowledge about the task that is being supported. And they're only good if training is undertaken, and that you have the background knowledge. And of course, people work with these systems, and people aren't always good at doing what they're supposed to be doing, whether they've been trained or not. People have different attitudes to computers, don't they? People regard computers as essential to their work, but sometimes they have they feel that they don't do what they want them to do, and indeed that is true. And we see errors because people override or ignore messages which are there to stop them issuing ABO incompatible blood, or make sure that specific requirements are met. We've seen people use other people's ID badges or logon details to gain unauthorized access when they might not necessarily have been trained. And then in the both the laboratory and the clinical area, we've got errors occurring because people are unfamiliar with the IT systems, and sometimes that's their own system. Sometimes they've moved from another place where the system works differently. And there is definitely concerns about delay. There's concerns that you won't get blood when you need it. And there are emergency functions, both in clinical systems and the laboratory systems, that you can use, but they aren't always used appropriately. They're sometimes used to bypass things when you can't do what you want to do, so because you're unfamiliar with the system. So this is data from our SHOT WEG looking at 4 years, and just to show you where all the IT errors come from. So there are very few transfusion reactions that are related to IT. So these are mainly specific requirements not met, incorrect blood component transfused, and to a certain extent, handling and storage errors because of the equipment side of things. But if you look here, 44% of all of these errors are due to the flags, alerts, and warnings that we have in place. So it may be that the flags are not used or not set up. It may be that the flag is in place but hasn't been correctly updated and is not correctly reflecting the clinical situation, or that the flag does work but it's heeded and overridden in some way. And then, of course, the other IT things that you get are where the systems aren't joined up properly. So the information is there, but it's not necessarily on the system that you're working on. There might be discrepancies between your laboratory and clinical systems, or you may have records that have not been linked or merged or reconciled in some way. So that's nearly another 20% of errors are due to these sort of things. So that's what we need to be concentrating on when we want to get it right. And certainly in 2016, we made this recommendation that if we're going to get alerts working, we need to work together. So we need to say as laboratory and clinical people what we want. We need to work with the industry so that they have standard flags. And there needs to be a mechanism of recording why something has been overridden, because sometimes that has to happen. We need to be able to deal with multiple special requirements. And also there's this concept of alert fatigue. If you keep on getting alerts and you keep on having to deal with them, then you can make mistakes, because when those alerts need to be dealt with in a certain way, you've moved into an override mode and you don't necessarily follow them. So there should be ways of standardizing this. Probably the biggest recommendation SHOT made in relation to IT was in 2017. And this was to say, and you'll remember my original 1999 report. We now say that all information technology systems to support transfusion practice should be considered, and they must be implemented to their full functionality. So a little bit about what I was saying about electronic issue, but there are other systems that are just not doing as much as we know that they can do. And then in the clinical arena, you should consider these systems in all clinical settings where transfusion takes place. And rather than being visionary and innovative as it was at the beginning, it's now something that everybody should aim for. And of course, SHOT went back. This was key recommendation 2. We went back and we asked people what they had done in relation to this. And it was encouraging to know that the number of people who already had systems to support collection of blood, but disappointing that few people had electronic patient identification systems for sampling and administration, although encouraging to see that this recommendation had probably encouraged people to move towards that. And when we asked people, why aren't you doing this? They said, well, time was a constraint, as was cost. And we know these systems take a long time to implement properly. And we know that they do increase healthcare costs, even though they might save in other areas. And then other people said that there were competing priorities, and that was a barrier to implementation. And of course, some people said, well, we've looked at our systems and they work perfectly well, thank you very much, without these systems. And that's fair enough. So if we look at the wider piece, if we look at what we want IT systems to do for us, I mean, just like our own mobile phones do all these things, they're simple, they're easy to use, they're intuitive. We want our IT systems in healthcare to work like this, and we want to speak to the people who are developing the strategies for all of our respective countries to make sure that they listen to what we need. We also want them to be compatible with current equipment. We want them to help us, not hinder us, so that they enhance workflow and don't disrupt workflow. And then we want them to work across the whole hospital. So if a change occurs somewhere else in the hospital, or there's a national change in guidelines or an international change in standards, we want those systems to be able to keep up to date and to give us all the benefits that we need. And absolutely, we want them to be interoperable, both within the lab and within clinical systems and within non-transfusion clinical systems as well. And of course, I suppose the concern is always, the more dependent we get on these things, what do we do when they're not working? And they might not work for technical reasons, but also we've had some fairly high profile cybersecurity attacks on our healthcare system. So that is always a worry. So just to summarize the learning points, I would say, these 4 points I think are really important, and the take-home messages. First of all, electronic blood tracking systems should be implemented for all aspects of storage, collection and administration. They do identify errors, and they can be used to prevent errors. But just remember that when staff become more reliant on these systems, that they are supportive. They shouldn't replace our checks, and they are confirmatory checks. The second thing is that IT systems are increasingly used to support patient safety, but they must be configured correctly and used appropriately and interfaced, and people must be trained. And the flags, which I've mentioned already, should not be easily overridden, and their application should not be complex or multifaceted. They should help the way we do things. And there should be a robust process in place. SHOT has just issued a new a safety alert about specific requirements, but in the laboratory there should be a timely way of updating flags and making sure that they're in place. So that's really all I want to say. This is one of our nice IT SHOT signatures around IT. Thank you for your attention. As we said, we'll answer questions at the end, and there is my email address if anybody wants to contact me directly. Thank you very much.